Hello, I'm Dr. Jessamine Dakanay, and I'll be discussing the disorders of the mediastinum. This is found in your Harrison's 20th edition, chapter 289. So the learning outcomes for this lesson will be to recall the anatomy of the mediastinum, learn the mediastinal masses, the acute and chronic mediastinitis, and the pneumo mediastinum. So first, let's recall the anatomy of the mediastinum. So the mediastinum is the region which is found between your lungs or your pleural sacs. And it is separated into your three compartments. You have your anterior mediastinum, your middle mediastinum, and your posterior mediastinum. So your anterior mediastinum is bounded anteriorly by the sternum, posteriorly by the pericardium and brachiocephalic vessels, and it contains the following structures: your thymus gland, anterior mediastinal lymph nodes, internal mammary arteries, and veins. Your middle mediastinum is found between the anterior and posterior mediastinum. It contains your heart, ascending and transverse arch of the aorta, your vena cava, brachiocephalic arteries and veins, phrenic nerves, trachea, main bronchi, contiguous lymph nodes, as well as the pulmonary arteries and veins. Your posterior mediastinum is bounded anteriorly by the pericardium and the trachea, and posteriorly by your vertebral column. It contains your descending thoracic aorta, your esophagus, thoracic duct, azygos and hemiazygos veins, as well as the posterior group of mediastinal lymph nodes. So the first condition we can encounter in your mediastinum are your mediastinal masses. Okay, so the first thing to do when you encounter a mediastinal mass is to try to determine which mediastinal compartment did the mass originate from. So usually CT scan, your computed tomography, is the most valuable imaging technique in order to evaluate these mediastinal masses. Other diagnostic exams you can do would be to do barium studies, especially if you're considering a GIT lesion. So this is indicated for your posterior mediastinal lesions since it can diagnose your hernia, diverticula, and achalasia. If you're thinking of an intrathoracic goiter, then you can request for an iodine 131 scan. Another diagnostic would be to do your mediastinoscopy or insertion of a scope into the mediastinum, or surgical exploration, your anterior mediastinotomy, for a more definitive diagnosis in your anterior and mediastinal masses. There are other methods to establish diagnosis without doing your open thoracotomy. Some would include your percutaneous fine needle aspiration biopsy. So percutaneous meaning passing through the skin in order to obtain a biopsy from that mass. Another is your endoscopic transesophageal biopsy, meaning we insert a scope into an endoscope into the esophagus and get a sample of the mass which is usually adjacent to the esophagus. Another is your endobronchial ultrasound guided biopsy, or your EBUS. So with your EBUS, we insert the bronchoscope into the bronchus and try to visualize the surrounding structures using ultrasound and get a tissue sample or biopsy of that mass surrounding your bronchus. And another option is to do VATS, your video-assisted thoracoscopic surgery or thoracoscopy. So they insert a scope into the mediastinum, and this can be diagnostic, and it can sometimes be therapeutic. If the mass is small, then they might be able to remove that mediastinal mass during the thoracoscopy. Okay, so this is just a summary of your three compartments. Again, your anterior, middle, and posterior compartments, their contents, and take note of the different abnormalities or masses which you can encounter in the different compartments. So for example, if you encounter a mass in the anterior compartment, then think of the following abnormalities or lesions. So you can have a thymoma, lymphoma, teratoma, thyroid masses, parathyroid masses, mesenchymal tumors, your giant lymph node hyperplasia, and even a hernia through the foramen of Margagli. If you see or find a mass coming from the middle compartment, then think of the following possibilities. You can have metastatic lymph node enlargement, granulomatous form of lymph node enlargement, presence of pleuropericardial cysts, bronchogenic cysts, and masses of vascular origin. And finally, if you encounter a mass which is found in the posterior mediastinum, then think of the possibility of your neurogenic tumors, meningocele, meningomyelocele, gastroenteric cysts, esophageal diverticula, a hernia through the foramen of Bokdalet, and even extramedullary hematopoiesis. Okay, so that is all for your masses. The second condition is your acute mediastinitis. So mediastinitis, meaning there is inflammation and infection in your mediastinum. And this can be due to three possible causes. So first would be esophageal perforation. Second could be your median sternotomy, after median sternotomy for your cardiac surgery. And third is an infection descending from the neck and oral cavity or facial area. So patients with acute mediastinitis are acutely ill. They are usually febrile with chest pain and difficulty of breathing. Okay, so your first possible cause is an acute mediastinitis due to esophageal perforation. Your esophageal perforation can actually occur spontaneously. For example, if a patient sneezes while pinching the nose and closing the mouth. So you try to avoid doing that, pinching the nose and closing the mouth at the same time because of the force of that sneeze, which can actually rupture the esophagus. So this can happen spontaneously with sneezing. Another would be a complication during esophagoscopy or insertion of your Stenson Blakemore tube. So esophagoscopy is an endoscopic procedure, while your Blakemore tube insertion is done for management of your esophageal varices. So how do we treat patients having acute mediastinitis? So we need immediate surgical exploration of the mediastinum. So you have to open the sternum of the patient, explore the mediastinum, find the tear in your esophagus and repair that tear, as well as drain the mediastinum and the pleural space of that infected fluid or pus inside the mediastinum. So another cause is mediastinitis occurring after median sternotomy. So median sternotomy is the incision made when we're doing an open heart surgery, such as your bypass surgery. So the incidence is actually quite low, 0.4 to 5% of cases. the most common presentation of which would be finding of wound drainage. So we have to check after the surgery if the wound is healing well and there's no pus draining from the area. So other symptoms would be a septic patient, hypotensive, febrile, and on chest x-ray, we might encounter a widened mediastinum because of the inflammation and the presence of that pus inside the mediastinum. So to diagnose, we need to do needle aspiration of that fluid in the mediastinum and send the fluid for tissue culture. And we need to treat the patient immediately by opening again that sternotomy. So very morbid since your patient just underwent an open surgery. You have to send the patient back to surgery and drain that infected area or debris the area. And you also have to immediately start the patient on your intravenous antibiotic therapy. However, despite adequate management, your mediastinitis after median sternotomy carries a high mortality, more than 20%, which is why we try as much as possible to avoid these conditions. And your last, another condition is your chronic mediastinitis. Okay. So chronic mediastinitis can actually range from a granulomatous inflammation of the lymph nodes in the mediastinum, so this is your granulomatous mediastinitis, to a widespread fibrosis in the mediastinum, so this is called your fibrosing mediastinitis. So the more common cases would be due to histoplasmosis, which is a fungal infection caused by histoplasma, or very common in the Philippines, you have your tuberculosis. Other causes of your mediastinitis, chronic mediastinitis, are your sarcoidosis, your silicosis, as well as other fungal diseases. So your granulomatous mediastinitis, since this is just a granulomatous inflammation in your lymph nodes in the mediastinum, this is usually asymptomatic. On the other hand, your fibrosing mediastinitis, since there is widespread fibrosis in the mediastinum, your patient can develop symptoms because of the compression of your mediastinal structures. This includes your superior vena cava, your large airways, your phrenic nerve, your recurrent laryngeal nerve. It can also obstruct your pulmonary arteries as well as pulmonary veins. So treatment for your granulomatous mediastinitis, we just have to treat the underlying cause. So the patient has TB, then you treat the tuberculosis. However, for your fibrosing mediastinitis, we would need to place stents. So these stents are usually placed to relieve the symptoms if you have obstruction of certain structures such as your veins and arteries to relieve the symptoms. Okay, another condition in your mediastinum is your pneumo mediastinum. So pneumo meaning air and mediastinum. So you have air in your mediastinum. So there is presence of gas in the interstices or the soft tissue in your mediastinum. So you have three main causes of your pneumomediastinum. First is your alveolar rupture with dissection of air into the mediastinum. So for example, if you have a patient who is on mechanical ventilation, your ventilator gives positive pressure breaths to the patient. And this positive pressure can actually lead to alveolar rupture, and that alveolar rupture can lead to entry of air into the mediastinum of the patient, so leading to your pneumomediastinum. Another cause would be the perforation or rupture of the esophagus, the trachea, or the main bronchi, which can be seen in cases of your vehicular accidents or your blunt force trauma. So these accidents or trauma can lead to rupture of your esophagus and trachea, and this will lead to the, again, entry of air into the mediastinum. And the third cause would be dissection of air from the neck or the abdomen into the mediastinum. So for example, if a patient is undergoing laparoscopic surgery, they usually instill air into the abdomen so that they can have adequate space to perform the surgery. However, that air in the abdomen can actually leak into the mediastinum, leading to your pneumomediastinum in these cases. Okay, so symptoms, your patient can experience a severe substernal chest pain, and this can occur with or without radiation into the neck and arms of the patient. And on physical examination, you would encounter subcutaneous emphysema or air, which is found underneath the subcutaneous tissue, particularly in the anterior chest wall and the suprasternal notch. So this is similar to when you're trying to pop your, uh, your bubble wrapping. So when you press a bubble wrap, you feel that popping sensation. So that's actually what you will feel if you try to press on the anterior chest wall of these patients. So that's your subcutaneous emphysema. Or you can encounter the Hammond's sign or Hammond's crunch. This is a crunching or clicking noise, which is actually synchronous with the heartbeat and is best heard on the left lateral decubitus position. So what happens when you put the patient on a left lateral decubitus position, your heart moves closer to the sternum, and it moves, as it beats, the heart beats, your heart moves to and fro, and this causes compression of that air in the mediastinum. So every time your heart beats, it will compress on the mediastinum, leading to that crunching or clicking noise, which we call your Hammond's sign or Hammond's crunch. So diagnosis, we usually do a chest x-ray, and you would notice here that there are black lines found on the neck of the patient. This is your subcutaneous emphysema. And you would notice also that there is a black line found between the heart and the lungs. So usually there is no space between the heart and the lungs since your pericardium and pleura are adjacent. However, when you have pneumomediastinum, you have air in the space between the heart and the lungs, which is why you have this pericardial pleural line, which is visible on X-ray. Okay, treatment. There's usually no treatment required, especially if you have just a small amount of air in your mediastinum. And you can actually give the patients high concentration of oxygen in order to facilitate reabsorption of that mediastinal air, similar to your pneumothorax management. However, if you have a large pneumomediastinum, then you might need to do needle aspiration of the area. This is usually guided, and this is only done if you have signs of compression in your mediastinal structures, since your needle aspiration also comes with some risk when doing the procedure. Okay, so that's all for the mediastinum. It's a very short chapter, and I hope you understood most of the topics that we discussed. Thank you.